Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I am the chair-elect of BTOG. This is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their fields and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancers. It is important to say that sponsors of BTOG do not have any role whatsoever in the planning, delivery, content of anything discussed today. Hello and welcome to another BTOG podcast. It's been a while since we've done one of these. In fact, I think we've had about a 4-month gap, but we're back and we're going to restart our podcast, continuing what we were talking about, the similar theme last time, and that is mutation-driven lung cancers. And we've gone through a number of these in a number of podcasts. We've done EGFR, we've done ALK, and so on. And today we're going to focus on MET, and MET as a driver for lung cancer, what we know about it, how we can diagnose it, and of course, most importantly, how we can treat it. I'm absolutely delighted to be joined by my friend and colleague, Alastair Greystoke. Ali is a medical oncologist based in Newcastle. Ali, welcome to this BTOG podcast, and thank you for joining us.
Thank you very much for inviting me.
So, first of all, we're going to start with the basics. MET, M-E-T, what is it? Can you explain that to our audience?
Yeah, so it's an oncogene. Like EGFR, it's a oncogene that's expressed on the extracellular membrane, and it's normally activated in wound healing and cellular growth and things like that. And it becomes overactivated in a number of different cancers. So it's not just lung cancer, but gastric cancer, colorectal cancer, breast cancer, a number of them.
Yeah.
And as we'll come on to talk about, it gets activated in a number of different ways. And it can be a primary oncogene in lung cancer, so it can be the primary driver, but also it can be a mechanism of resistance to some of the other tablets that you talked about earlier in this series.
So just to explain that to people who may not be so familiar, when you say a primary driver, you're saying that is the main cause of the
Yeah.
cancer, whereas
Yeah.
sometimes you'll see it and it won't be the main cause, but it's the reason why a drug has become no longer effective or worse than that effect.
Exactly. So sometimes it's the thing that causes the cancer in the first
Yeah.
place, or presumably one of the first hits in the sort of changes as you go from benign to malignant. And sometimes it's a later on process that comes on with mostly our targeted treatments.
Now, there's quite a few alterations in MET, and that can be quite confusing. And I think it's quite easy sometimes to get muddled by them. And we're going to focus a lot of our discussion on a particular mutation called MET exon 14 skipping. But people may also know that you can get MET amplifications and other such alterations. Could you explain to us the difference between MET exon 14 and the other alterations in MET that we can sometimes see?
Yeah. So the most important one in terms of treatment, and the one where we have a licensed treatment for, is MET exon 14 skip lesions. And unfortunately, this is a bit more complex than things like your EGFR or your ALK, because
Okay.
it's over 200 different abnormalities that can lead to MET exon 14 skip. But they all have the same functional consequence. So exon 14 codes a little bit of the protein that sits just under the membrane. And normally that's where the cell tags it for degradation and for breakdown.
Hmm.
And so what happens in MET exon 14 skip is you lose that bit of the protein. So the cell doesn't tag it for breakdown and it accumulates in the cellular membrane. And so then you've got large amounts of this oncogenic switch that the cancer cell can then use to drive itself forward, grow, and spread. It
Okay.
can also be associated with amplifications as well, and nearly always would be associated with overexpression of the protein because of the mechanism that causes. Okay.
And can you explain to people who may find that reference to amplification difficult or confusing, what do you mean by MET amplification?
Yeah. So MET amplification is so MET is, as we've described, as a switch. And so MET amplification is when you've got multiple copies of the gene that code for that switch. Again, so you get multiple copies of the gene, and the cancer cell can then use that to drive it forward. That's opposed to an EGFR mutation where the gene is mutated and switched on. So it's a switch on mutation. This is
Okay.
multiple copies, a bit like HER2 in breast cancer, maybe, is the thing that people may
Yeah.
be
Yeah.
most familiar with.
Okay. So increasing, that's very helpful. So different processes, MET amplification versus MET exon 14. And so presumably different ways to detect them. If you were to have your ideal way of detecting a MET exon 14 skipping mutation, how would that be? What works and what techniques don't work?
So there's lots of different ways that can be used. As I said, it's complicated and there's a
Yeah.
number of different abnormalities out there. And realistically, the only way you're going to pick them all up is next generation sequencing. So
Yeah.
sending your tumor to your genomic laboratory hub for a panel test, which is the best way to get all your other abnormalities at the same time.
Hmm.
But to sequence across that region from exon 13 all the way through to exon 15, where you see these abnormalities, these 200 abnormalities that can cause a problem, that's the best way to do it. Um, Mostly you will pick it up on DNA analysis. You don't, it's not like some of the fusions, which are really difficult to pick up on DNA analysis, and you often need to send an RNA sample as well. You will pick up one or two extra on RNA analysis, but actually most of the time you can pick these up on DNA analysis. Um, People talk about using like PCR-based technology tests like that. Some of a lab on a chip, people say they can capture these. I have to say I'm fairly skeptical about that. These are very complicated abnormalities, and actually, even in a good laboratory, they often have to think long and hard about the functional consequence of, they've read the DNA. Does that actually lead to the MET
Yeah.
exon 15 skip? Does it lead to the activation of the switch? And is it a good target for us for our treatments?
So if you're uh, have a service and your service does not unfortunately stretch to next generation sequencing, you cannot be too confident that you are picking up your MET exon 14 skipping. Is that a fair thing to say?
Yeah, you'll miss them.
Yeah.
Yeah, you'll miss them.
And what about those of us who have access to circulating tumor DNA, perhaps through the NHS England pilot or through other things? How good is that at picking up the skipping mutations?
So it certainly can pick them up. In the trials of tepotinib, which we'll come on to talk about half of the patients got enrolled on the basis of circulating free DNA abnormality picking up MET exon 14 skip. So I think you can pick them up. You can miss them as well because it's a complex abnormality, and circulating free DNA is very chopped up. But I've had many patients where we've picked it up on circulating free DNA.
Okay, that's helpful. Now, MET amplification, very different mutation. How are we going to pick that up? And that's, I think, notoriously difficult. And sometimes there's a lot of variation how we want to define it.
Yeah.
What are perhaps the commonest ways of trying to detect a MET amplification?
Yeah, so the ways that were used in the trials, and it's probably still the gold standard, is what's called FISH, where you put a probe on each copy of the MET gene and you count the number of genetic
Mhm.
abnormalities, the number of dots, maybe in comparison to a different gene on the same chromosome, so you can be sure it's that the MET that's increased and not just the
Yeah,
chromosome. Um, that's probably the gold standard. Next generation sequencing, you will pick it up because you'll see more copies. As you sequence, you'll read lots more copies of that gene, and you'll know that it's amplified. But if you have low tumor content, it can be quite difficult to work out exactly what the amplification is, and that may be important in treatment decisions. Circulating free DNA, yes, you can pick it up as well, but again, if you're trying to pick up an amplification and there's only very low levels, you could easily miss it. If you're trying to pick up 3 or 4 times the amount of DNA in the particular gene, but it's only there in 1% of the DNA in the circulation, you could easily miss that.
yeah,
So gold standard tumor biopsy, probably next generation sequencing to look at it. But if you really want to know the exact copy number, you may need to follow up with something like a FISH technique.
yeah. And I think what I'd say to people is when you have your molecular pathology report, read every page. Certainly the pages we get the DNA, then we get the RNA. It's actually on page 4 that you can see the amplifications. And if you haven't gone down that far because you think you've got the references, look carefully because it's often there actually.
A
Okay.
couple of things just to say about that. Sorry, Tom.
Yeah,
One is that as of about 6 weeks ago, all the genomic laboratory hubs should be reporting MET amplification on all biopsies. It's gone onto the
that's very
national
helpful to know.
directory. But also, don't be afraid of asking your lab. These are complex reports.
Yeah.
Get to know your lab person, and if you're not clear, please just ask somebody.
Yeah, absolutely. I think that's such an important message, and that no one, you should never be embarrassed not knowing. I spend a lot of time annoying people by email saying, please explain this.
Yeah.
Um, okay, so we're going to focus a bit on the MET exon 14 from here on, because that's the most relevant, I think, to most of us in routine clinical practice. Could you describe a typical MET exon 14 patient, or is that not the case? Is there no particular difference in age, demographic, tumor type?
No, there is a little bit of a demographic. They're different from your EGFR and your ALK, so they're a bit older.
Yeah. Yeah.
So the average age is about 73, which is about the same as all our lung cancers in the UK, and that's reflected actually in the trial population.
Yeah.
Slight preponderance for female, and a slight preponderance for non-smoking. But where I work, we commonly see it in smokers.
Yeah.
So I would say your most common patient is in their late 70s, female, smoked a bit 20, 30 years ago.
Right. And is it a good mutation to have? And that sounds facetious, but we do have good mutations where there's high response, or is this a marker of an aggressive cancer?
Yeah, no, it's an aggressive cancer. So there's been numerous meta-analyses that show these patients have poor prognosis if you don't treat them appropriately. We'll talk about how good the treatments are, but certainly, following surgery, radiotherapy, even chemotherapy, this is a poor prognostic group.
Are we seeing reduced and lower responses to chemotherapy? And we'll get on to targeted therapies in a second. Have you seen it in that way, or is it just it's relapsing more quickly after radical treatment, for example?
Certainly relapsing more quickly after radical treatment, certainly associated with poorer overall survival. Response rates to chemotherapy are put at about 25, 30%, so maybe
It's
slightly lower, but
definitely lower, isn't it?
PFS is probably less than you would expect standardly.
Yeah. Yeah. So, I mean, I guess we always like to find a mutation, but I guess there are good mutations and less good mutations. I think this forms into the less good one. What about histology? I mean, I was struck, the most recent patient I had who diagnosed with MET, which was about 2 months ago, was picked up on a ctDNA of a patient with squamous cell lung cancer. So we do see it in more than one histology type, don't we?
Yeah, it's about 70, 80% adenosed. And then you see it in squamous, 1, 2% maybe. The classic was, so there's a paper about 7 or 8 years ago that said pleomorphic or sarcomatoid had 1 in 4 had it. And I was like, oh, so every time it came up, I was like, oh, we must test for it. I've never had one yet, but they've dropped that down a little bit. They now say it's about 10% of pleomorphics
Okay.
have metexon 14, but it's not just adenocarcinomas.
And that would kind of add to our approach that really we should be trying where we can to do reflex testing of all patients,
Yeah,
because you will miss things otherwise.
definitely, and it's probably one of the more common abnormalities that you'll miss in squamous cancer. Unfortunately, our guidelines at the moment say under 50s or under 55s and light smokers, and a lot of these patients would not be
Yeah.
picked up by
Yeah.
that approach.
Yeah. No, I absolutely agree. I think it's very easy to miss that. Are there any particular different staging investigations? When we know someone has an ALK, for example, fusion, we will always want to make sure we do cranial imaging. Would you do the same with this? Are you worried about different pattern of metastases, or should people just go down the standard diagnostics for a patient with stage 4 disease, which is what we're focusing on here?
Well, you could argue that all stage 4 lung cancers should have brain imaging. That's
You
an
could.
argument for another day. It's
Yeah.
about equivalent for the non-oncogene driven lung cancers. It's not like your EGFR or your ALK. It's about 15, 20% will have brain metastasis. So
Yeah.
yes, maybe consider it. We're going to be talking about TKI treatment. The tablets do get into the brain, but maybe you might want to know it for prognostic information and also
Yeah.
to look out for resistance in the brain.
Yeah. Okay, talking about which, good segue. We're going to talk about the targeted therapies. These are comparatively new, and we do have them available and reimbursed through NHS England, certainly. The ones we have at the moment, so tepotinib is available, capmatinib is licensed, but as far as I know at the moment, not available in UK. But these weren't the first ones. Various attempts have been made to target MET over the years, largely with less success. Can you just give us a brief overview of that, just so people say, "Oh gosh, I remember that drug,"
Yeah.
and I remember didn't get very far.
Well, the one they'll probably remember is crizotinib, which actually was originally designed as a MET inhibitor, and then they found it was an ALK inhibitor
Yeah,
by serendipity. So that was looked at in the phase ones of crizotinib going back when you and I were just emerging out of the fold of being registrars, and and showed some responses. In fact,
yeah, yeah,
we used it within Matrix. For those of you going back a while, so I treated some patients with it on Matrix. The Americans thought it was quite good. They said responses are 30 or 40%, and length of response 6, 9 months, which is all right. The French thought it was rubbish. They said responses are 30 or 40%, but none of them lasting beyond the first scan. So yeah.
Yeah.
It got supplanted, let's put it that way, by newer inhibitors.
Yeah. Yeah. And those new inhibitors, capmatinib, tepotinib, can you give us maybe a view on their general efficacy, response rates? These are both oral therapies, obviously. Is there an obvious one better than the other, or are these Pepsi versus Coke?
I think it's Pepsi versus Coke, and you can work out which one's which. You know, they've both been evaluated in large phase 2 studies, which led to FDA and European approvals. They've both recently actually presented relatively up-to-date clinical data with long-term outcomes on those studies, but both of them sort of had 100, 200 patients, a bit larger in the Vision 1, which is tepotinib study. But I don't think you can compare them, different populations, different inclusion, exclusion criteria. So I think we just have to say that they're
Mm.
two therapies that have reasonable clinical data. Neither as good as we would probably like for our patients, but both reasonable and something that we should be offering in the first line setting.
And in that first line setting, what kind of response rates can people expect, and what kind of duration of activity are we seeing?
Yeah, so both studies suggested that the response rate was slightly higher if you gave it first line and subsequent lines.
Yeah.
So in the first line, they're sort of talking about 50, maybe 60%, as opposed to 40 to 50% in subsequent lines. Um, Median PFS around about 9 months to probably a year. The latest tepotinib data suggested your duration of response was really long in the first line setting. So they had a median PFS of about a year, but a duration of response about 3.5 years. But that was because the curve was basically all centering around about the 50% mark. So it was a really unstable estimate of duration of response.
Mm.
So I think that was a bit of an overcall, but
I certainly haven't seen that in my clinical experience, sadly. It's been much nearer the 6 to 9 months, and it feels a little bit like a not very good EGFR TKI, and you have a period of stability, and then 6 months in, it's beginning to wear off.
yeah. It's a
And
bit better than some of the other ones, but
yeah,
it's not the bottom of a league, and we won't mention those to save their embarrassment. But it's certainly not up there with the EGFR inhibitors or the
no.
ALK.
And side effects, there's a bit of a class effect with edema. I mean, that's the main
Yeah,
issue, isn't it?
yeah, and this is it's a real problem because we're talking about an older female population, so probably 40-50% of them are getting some form of edema. About 1 in 10, maybe even more in my experience, getting significant edema. And it's difficult to manage both from a medical point of view, but in terms of impact on the patients, because
Yeah.
if their legs suddenly weigh 4 or 5 more
Yeah.
kilos to the edema, they really struggle with their mobility and they notice it.
Yeah, yep. I've seen someone recently, exactly that, and they're hugely reduced quality of life, and wearing the kind of slippers you have to cut open to get them on. Um, any other particular? We'll get on to edema in a second, but any other particular side effects? We know a little bit of liver function test abnormality with both agents, particularly tepotinib. I know it's in their SPC.
Yeah.
Um, any others that spring to mind, or are these quite easy drugs to take?
Yes, it's a couple of lab abnormalities you need to be aware of. Well, so number one is low albumin. You'll nearly always see a low albumin, and it'll
Yeah,
come down to the sort of high 20s normally, low 30s, high 20s, and that's relatively common. The other one just caught me out the first time because I wasn't expecting it. It's like with some of the ALK inhibitors, you can see a rise in creatinine.
yeah.
And that may or may not be associated with renal dysfunction, but it's an effect on the transporters in the kidney. So you get an artifactual rise in creatinine in the blood.
Yeah, that's really helpful to know. Um, and availability. So
Yeah.
NHS England, appreciate it does not cover Scotland. We have tepotinib, which is covered first line,
Yeah.
and I think we also have access to it still second line, don't we?
Correct.
So if
Totally.
if you have missed the boat, and I guess we would probably say we'd recommend giving these drugs as first line. But you happen not to know, or you had a delayed result, you can still use it post platinum-based chemotherapy. What do you know? The situation in Scotland? I must admit, I don't. I'm afraid to say.
No, I'm sorry. I should have checked. I should have checked.
Yeah.
My apologies. I don't know.
Apologies, colleagues north of the border. We should know that. Um, the bottom available capmatinib not currently available. Just thinking about those side effects again. So with the edema, which I have seen almost to be universal,
Yeah.
um, diuretics, do we use them? Do they help? Do they just annoy people?
Yeah. People won't be able to see. I just made a face. Um,
You did.
it doesn't really work on podcasts.
No.
The problem with the diuretics is they don't really work, and all you're then doing is asking your 75-year-old lady who's got carrying around 5 kilos on her legs to walk more frequently to the toilet.
Yeah.
So once they do suggest you can use them, I'm not a great believer. Lymphedema services are helpful if you've got access to one, but we don't often have access to them. The main thing I would say is this is a drug where you can use lower doses,
Yeah.
and I would encourage it, getting the patient on the right dose for them. So it's a 50% dose reduction, and often that will help, although it doesn't always completely get rid of the problem.
And some people using forced diuresis and albumin infusions. Is that something that you do, or is that not something which is going down in the Greystoke domain?
No, not tried it. If it works, great. I'd be very interested here. Anything that can help. But no, education is key, actually,
Yeah.
though. Explaining to the patient that this will likely happen
Yeah.
is important.
And just to say to people, the edema is, commonly in the legs, but I've also seen it affecting the face,
Yeah.
which goes down very badly. And I must say, the only thing I've ever seen that works is a dose reduction,
Yeah.
unfortunately.
Agree.
Um, okay, so those are the main side effects. What would be your kind of paradigm if you knew the MET result up front because of your outstanding genomics result? Are you reaching for your MET inhibitor first line? Are you keeping it second line? And then if you are using it first line, what do you use after that?
So I use it first line.
Yep.
Couple of reasons. A, the clinical data looks a bit better first line than second line.
Hmm.
B, we've already talked about the fact that these patients may not do as well on chemotherapy, and or maybe immunotherapy, and you don't want to miss the boat. Until recently, the blue tech forms didn't help you. They actually hadn't taken account of previous MET inhibitor treatment. It said you weren't allowed to use it if you'd had previous SACs for your cancer, and but that's now been changed. So you can now give NHS England recognises you can now give tepotinib and then give chemo IO if you want to.
Yeah.
It was just, we just needed to get the form adjusted from NHS England. So that's what I tend to do.
And when they have progressed on tepotinib, unfortunately, would you reach for chemo? Would you reach for chemo IO? Is this a situation where we're wasting our time shoving in immunotherapy, or actually does it have a role?
I don't think we really know if they're fit. I tend to use chemo IO.
Hmm.
A lot of these patients aren't fit, but MET is associated with a higher tumor mutational burden than some of like the EGFR and the ALKs, more co-mutations. So, and there is some data showing that they can do okay with immunotherapies. So I would tend to use chemo IO.
Hmm. Yeah. Yeah. And then third line, is there anything exciting beyond docetaxel? Do we have any other clever ideas?
Trials.
Yeah.
This is one
Yeah.
area where there are quite a lot of trials, which I guess we'll come to talk
Yeah.
about. So certainly I've got a trial that I would try to point patients towards if fit.
Excellent. So, talking about which, what is new coming through? Feel free to plug your own trials here. Do we have anything, any next generation MET inhibitors about to appear in phase threes, or are we looking at earlier in the pipeline? And how can we do better than what we've got at the moment?
Yeah. So, well, amivantamab, we did a cohort of amivantamab in MET exon 14. It actually had reasonable activity, but it doesn't look like that's going forward. Most of it's based around antibody drug conjugates, because you've got
Hmm.
MET on the extracellular membrane. We've said it's going to be associated with increased expression. MET IHC, sorry, immunohistochemistry is really easy. So there's a potential biomarker, and there's a number of antibodies that are already out there. So it's been a relatively busy area for quite some time. Nothing outstanding as yet, but I think, antibody drug conjugates chemistry is getting better. We're getting a better idea of how to use this. So there's quite a few of those around at the moment.
And just to remind people that amivantamab is an EGFR and MET bispecific, which is why
Yeah.
Ali mentioned it, and we know that is active in EGFR mutated lung cancer, and there's obviously for MET it might be a drug not without its side effects, mucocutaneous being the main ones. So you feel that ADCs are probably a way forward. Are people developing next generation TKIs, or is that less of a focus at the moment?
No, they are generating next generation TKIs, and if you look at mechanisms of resistance to drugs like tepotinib and capmatinib, some of them are MET driven, mutations and stuff like that that you might be able to target, but equally, some of them are bypass mechanisms. So I think it's going to be a tough nut to crack, actually,
Yeah.
Met.
Yeah. Um, when we have drugs in the advanced setting, we obviously often see them progress to the other settings. Do you see people using adjuvant, for example, tepotinib after surgery? Do we see people using this in the locally advanced setting? It's tempting to always think what works in EGFR and ALK will work in everything else. What's your view on that?
So there's a couple of platform studies coming. I think there's one coming forward in America, which will have a MET exon 14 cohort within it. So it'll be interesting to see how that goes. I think that's actually a neoadjuvant, like a window study
Mm,
approach. I would have concerns about using it in the adjuvant setting because of the tolerability.
yeah, yeah.
But I suspect it'll be something we'll look at. But maybe when we get a newer agent, but the problem is all the MET inhibitors we've tried do have this edema sort of class effect, even though it's poorly understood. So are we going to get a decent drug that doesn't lead to some of the side effects that may not be tolerable in the adjuvant setting?
I think that's absolutely right. I mean, we've seen it with osimertinib, which is an easy drug. Even that is the compliance is less than we would expect.
Yeah.
Um, Moving finally on to MET amplification, you talked at the beginning about MET as a resistance mechanism. We see MET amplification in other contexts, so away from the exon 14 skipping patients. And I might just ask you a little bit about that in the context of EGFR. So we know, have known for a while actually, haven't we, that patients on osimertinib, one resistance mechanism is MET amplification. Whenever I can, I repeat biopsies. I must say, I very seldom see it. I keep thinking I'm going to, and there's something about patients in Southwest London, we don't see that. What's your take on MET amplification as a resistance mechanism in EGFR? Do you see it very much? And if someone does see it, what might they do about it?
Yeah, we've had a couple of patients who've had it de novo, which is really
Mm.
confusing. What do you do then? So the problem at the moment is we can't readily do something about it. So there is pretty good data out there of some sort of phase two studies. The biggest one, I guess, is on Insight 2, using
Yeah.
tepotinib alongside osimertinib in patients that had progressed on osimertinib and had MET amplification found a number of different ways. And that showed a response rate in these patients that were already progressing on their osimertinib of about 50%. So that sounds wonderful. There's a couple of problems. I'll talk from the clinical point of view and then others. But from the clinical point of view, they didn't really seem to hold. So median PFS, I think, was 9, 10 months, which isn't great. It's better than nothing in a 50% response rate.
Yeah.
Some toxicity, as you'd expect with the tepotinib, and a couple of cases of pneumonitis. Um, but the number one thing is we don't have access to it in the NHS. The osimertinib, when you sign up to your Blue Tech, it says you give as per summary of product characteristics, which is as single agent. And
Mm.
appraisal was done on us using osimertinib until patients progressed and then for a few months afterwards. So if we are going to bring this forward, or if the drug company wants to bring this forward, we will have to do a separate nice appraisal if we are going to do
Mm.
it in the NHS. And I would welcome it, quite frankly. And I think that, if I was a patient, I'd want it. I'd want better than the 9, 10 months, but I would want it.
Yeah. And are there any other tumor types where we see MET as a resistance mechanism? Is it only EGFR or are we
It can be
seeing it
seen.
elsewhere?
It can be seen in all the targeted agents. It's a common bypass mechanism.
Yeah.
So,
Yeah.
um, yeah, ALK, RET, all of them, you can see MET amplification as a mechanism of resistance.
Ali, thank you very much. That's a tour de force. So I guess what we might summarize by saying there are lots of different alterations of MET. Read your report carefully. You're looking for MET exon 14 skipping and make sure you've got a DNA next generation sequencing. Otherwise, you probably missed it. It is in a slightly older patient group, and unfortunately, is not a great mutation to have because prognosis can be less good. The moment we have tepotinib, certainly south of the border, and we're ashamed that we don't know what's going on north of the border, and we apologise unreservedly. That can be used first or second line, funded that way, and there's evidence for both, but we would probably recommend using it first line. And edema is going to be the issue, and it is a challenge. In other words, we're not very good at managing it beyond dose reduction. And then you've given us some interesting information about possible things coming through, such as ADCs. So, Ali, thank you so much for that summary and for joining us this evening. Thank you to the audience for listening. We will be having some more podcasts, and I'll be introducing a new co-host in the near future, so you can look forward to the excitement of that. And thank you very much for joining us. For more information on BTOG, including education events and how to become a member, you can visit us at www.btog.org.